Thanks very much to all of you for joining us for this webinar. And for your information, the webinar is being recorded for the benefit of all, well, for yourselves and also benefit of other participants who may not be able to join us today. Um, we're really excited. This is the first one of a series of webinars around the Paris OECD initiative, Does Healthcare Deliver? And perhaps just to make you aware, there's a slight change of plan. As always, there's always something unpredictable in this kind of events. And unfortunately, one of the speakers, Michael Vandenberg, who has not been able to join us in spite of his best efforts because of some logistical aspects related to travel. But very luckily, we have also the other speaker, Candan Kendir, who I will be introducing in a minute, who is stepping up to cover the whole webinar. She was already ready to give a part of it. So just a word from myself. I'm Jose Maria Chema Valderas. I'm the chair of the Working Party in Quality and Safety. And Paris encapsulates many of the interests that are relevant to the activities we focus on in this Working Party in WONCA. The talk today, as said, is about Paris, and the other talks that we will have. We have another 3 talks on the 23rd of June and on the 6th of July, different seminars, webinars on Paris. And Paris offers a unique international comparison of healthcare quality as reported by people living with chronic conditions. So let me start by introducing our distinguished speaker, Candan Kendir. Candan is a health policy analyst at the Organization for Economic Cooperation and Development, the OECD. A key focus of Candan's work has been integrating the patient perspective into health systems performance assessment, in particular including the OECD Patient Reporting Indicator Surveys, PaRIS. Candan plays a pivotal role in the Paris initiative, leading co-development with patients, primary care professionals, and academics. And she has a strong background in health service research and international health policy. She has contributed extensively to advancing patient-reported measures and strengthening primary care systems. Before joining the OECD, Candan gained first-hand experience in primary care and emergency care and conducted research at the French School of Public Health, EHACP. She holds a medical degree with specialization in family medicine. She's one of us. And a master's degree in public health specialized in health policy, management, and social and behavioral sciences. Her work focuses on connecting policy, research, and practice through collaboration and co-development, ensuring that initiatives are both inclusive and impactful. So thanks very much for joining us today, this morning, tonight, across the globe. So over to you, Candan.
Thank you so much, Chema, and good day to everyone. It's really great to be here and presenting the work of the OECD on patient-reported indicator surveys. Chema presented very well who I am and what I'm doing. But to add on it, I started working on the OECD's Paris initiative in January 2020, thanks to a WONCA colleague, actually, who was in Paris while I was doing my master program to attend the task force meeting. So this task force meeting that the OECD held was to launch an idea that we would have an international survey in primary care settings for people with chronic conditions on patient-reported outcomes and experience measures. And thanks to this initial link, I started working on the project as of January 2020, and I worked extensively on the design, development, implementation, and the analysis parts. Today, what I'm going to try to show you will be just going through what Paris is all about, what we really measure, and the key results that are particularly relevant for the context of primary care and the everyday work of family doctors. So before I start with presenting the Paris, I want to remind us something crucial that you are dealing with in your everyday life, in your everyday practice, in your family practices and primary care practices. Healthcare is all about the patient. The reason why we have healthcare system is that because we have patients. But most of the time, what happens is that we don't ask patients how healthcare impacts their lives and how they experience it. So what happens is that policy decisions related to healthcare settings or primary care settings in this particular context are shot the dark. So in the dark. And that means that they might find the right target, but most often they fall just away from it. So why OECD and what OECD does? OECD is the Organization of Economic Cooperation and Development, and our motto is better policies for better lives. So we work with policymakers. It's an intergovernmental organization of 38 member countries, mostly highly industrialized countries. We apply economic analysis, and we have a health division, particularly related to health issues and healthcare systems. We have international data collections and harmonization of data. Maybe you might be familiar with the OECD's work with bar charts, all countries next to each other, benchmarking work. And what we try to do is use this data to have data-driven policies. And what we try to do is we bring together stakeholders, governments, and experts to find solutions. So what Paris does is we know that significant progress was made on health data collection. And these are mostly regarding healthcare settings about hospital beds, number of healthcare professionals, general practitioners, nurses, and so on. But we know that we have limited insights into patient-reported outcomes and experience measures. So what Paris tries to do is we try to fill this critical gap in healthcare knowledge by bringing data coming directly from patients about their health outcomes and care experiences. So it's a new international standard for patient-reported outcomes and experience measures. In 2023-24, we had international data collection of people from 107,000 primary care users age 45 and older in 1,800 primary care practices across 19 countries who pioneered the first data collection. So now we are working on the next cycle where we are expecting more OECD members to join. And just to remind very quickly what we mean, what we say patient-reported outcome measures and patient-reported experience measures. Outcome measures are any report of health status of patient's condition, and this should be without interpretation of a clinician or anyone else. So basically, this might be about physical health, well-being, social functioning. And when we talk about patient-reported experience measures, here we look at patients' views and observations about aspects of healthcare. So this might be about communication, coordination of care, and other things related to care experience. So it's great pleasure that we have been working with several stakeholders, including WONCA, since the very beginning in this work. So we have a patient advisory panel, healthcare professionals, academics, an international consortium of international experts have been working with us since the very beginning, and Chema has been one of the leads of this consortium, and also policymakers from the countries who have been working on this. And on the website of Paris, you might find all these technical publications that we have, Paris questionnaires, patient questionnaire, and primary care practice questionnaire, and the peer-reviewed scientific publications. Very quickly about the results. So what the results show us. We know that more and more people live with multiple chronic conditions. So when we asked the patients to join the Paris Initiative, we didn't know whether they had a chronic condition or not and which conditions they had. But we figured out that among these people aged 45 and older who had a contact in the primary care settings in the past 6 months, 82% of them live with a chronic condition. And among them, half live with 2 or more chronic conditions. And 1/3 of them live with 3 or more chronic conditions, which has big consequences for the everyday practice of family doctors and primary care professionals, actually. That means you have been dealing with these people who are a bit more complex in nature and resource intensive to deal with in a daily practice. And what else we know is that over 70% of people who live with multiple chronic conditions take at least 3 medications, and more than a third of them take 4 or more medications. So that also has consequences related to work of the group working party on quality and safety, where issues with patient safety can come into discussion. So we try to simplify how we measure the performance of healthcare system in delivering primary care. And what we do is we use 5 patient-reported outcome measures, as you see on the right side: physical health, mental health, social functioning, well-being, and general health. And then we have 5 experience measures on the left side: confidence to self-manage, experience coordination, person-centered care, experience quality, and trust in healthcare system. And what you see in this figure, in this radar chart, is that the dark blue one is the highest score that we got out of Paris results related to these indicators. And then the light blue is the lowest score in the countries related to each indicator, the lowest value. And orange is the OECD PaRIS average. And particularly when it comes to physical health, general health, confidence to self-manage, coordination, and trust in the healthcare system, we see big variations, big gaps across the highest and lowest performance countries, which bring us some questions about what really works in primary care settings from the perspective of patients. What we know about health outcomes of these people is that with each additional chronic condition, their social life gets worse. So here, what we look at is that this is the percentage of patients with chronic conditions reporting good to excellent social functioning. And the round ones are people with one chronic condition, which are relatively high. And the triangles are people living with 3 or more chronic conditions. And in the middle, you see people with 2 chronic conditions. You see that in all countries, people with 3 or more chronic conditions are less likely to have good to excellent social functioning. And what is also interesting is the gap, the difference between countries. In some countries, almost the people with 3 or more chronic conditions are as high as people with 1 chronic condition. And what we also see is that in some countries like Wales, Portugal, Romania here, the gap between those people are very large. So as soon as you have an additional chronic condition, you're less likely to experience good social functioning. Of course, there are many factors that can have an impact on social functioning of people, but still this gives us an idea about how some countries are managing this better than others and why. Another thing that I wanted to bring to this discussion is about different groups of chronic conditions. So it matters how many conditions you have, but also it matters which combinations of chronic conditions. Here, the rounds are people with concordant conditions. So these are conditions that share a common mechanism: cardiovascular, chronic kidney disease, diabetes. So we have established guidelines and platforms for this. And in the triangles, and without mental health conditions, these round ones. And the triangles are any 2 or more chronic conditions of which one is a mental health condition. In between, you see discordant conditions without any shared mechanism, but without mental health either. So what we see is that when one of those conditions is a mental health one, then the negative impacts on social life are also exacerbated. So this also brings us the importance of managing mental health in primary care settings as well, or the better integration of mental health care in primary care settings. Another important outcome that we see across patient groups is that women consistently report worse physical and mental health compared to men. And this is what we call gender paradox. We know that women tend to live longer, but not necessarily in good health. So this brings us to another patient group which require more attention. And the same thing goes for people with lower incomes. Here you see the difference, absolute difference between people with high and lower incomes. And we see that in all countries, people with higher incomes have better physical and mental health. And again, we see that in some countries, the difference is much larger than the other ones. Let's see here in Australia, for instance, the difference is not that much high when physical health and mental health. So far, these are the descriptives that we have from the Paris results about the population and the characteristics of how they report their health outcomes. But the important question here that the policymakers and also us as family doctors, we can also ask ourselves what we need, like what do patients really value in the healthcare systems? What matters to patients from their perspective? So here I try to structure it a little bit in line with the core dimensions of primary care. So access to primary care is the first one. And here I should open a parenthesis saying that as PaRIS was a survey of primary care users, so these are actually people who could access primary care settings, it's not the best one to assess access to primary care. Nevertheless, we also ask questions about whether they had any issues with access in the past. We also ask them about the waiting times that they have in primary care. So here I brought you some examples from different dimensions, and this is the first one. What we see about the long waiting times. Here on the y-axis, you see the percentage of patients who trust the healthcare system. And there are three groups. Those who took same or next day for the appointment following the initial booking. The second group is up to a week, and the third group is up to more than a week. And we see that when the waiting times are longer, less people tend to trust the healthcare system in general. The second dimension is about continuity, relational information and management continuity. And here, there are a few examples. First thing is more time with primary care professional is highly valued and associated with better experiences of quality of care. Here you see an example, a result of logistic regression that we had, and there are different dimensions that we looked at. And now I'll give you an example about the first one, relationship with provider longer than 5 years, which was found to be associated with better experiences of quality of care. But what we also see is that across countries, on average, here you see the percentage of people with multiple chronic conditions who have been with the same primary care professional for more than 5 years. And on average, it's about 60% of people. In some countries like Czechia, Romania, it goes up to almost 80%. Whereas in some countries, here you see Spain, Greece, Saudi Arabia, it goes less than 50%. So it really varies across countries about the long relationship that people can build with their primary care professional. But what we also know is that longitudinal professional-patient relationships go in hand with more trust. So we already know this longer relationship with the same primary care provider is highly valuable. And here you see the percentage of patients who trust their healthcare professional. And we see that as the number of years increase, the percentage of patients also increase who trust their healthcare professional, showing the importance of length of relationship in primary care again, but this time as reported by patients. Here an example about information continuity. So we asked people whether they needed to repeat healthcare information that should be in their health records or not. And here you see the percentage of people who trust their healthcare professional, primary care professional. The dark bars show those who did not need to repeat, and the red marks show those who need to repeat. And you see that immediately people are less likely to trust their healthcare system. If they need to repeat information, they should be in their health records. And we'll come back to that later on about the exchange of information in primary care. The next dimension is about comprehensive care. So here there are different dimensions, but the first one is about, again, time with primary care professional, but this time scheduled time for consultation. If it's more than 15 minutes, people are more likely to experience good quality of primary care. And what we see across countries is that about 50% of people with multiple chronic conditions are managed in practices with scheduled consultation time of more than 15 minutes. And the variation is huge across countries. Here in Norway, Portugal, almost 90% of patients are managed in practices with more than 15 minutes scheduled. Then in Netherlands, Wales, and Spain, almost 10%, only 10% scheduled time of more than 15 minutes, which is important to have comprehensive care when it comes to people with chronic conditions, particularly multiple chronic conditions, because there are different health complaints and issues to address in these care settings, in these consultations. But we also need to be careful while interpreting this, because it doesn't necessarily mean how much time is spent. And it's very likely that many family doctors are really taking more time with these people, but the scheduled time is not necessarily reflecting the reality. So that's another thing that we should keep in mind. But at least this shows how they practice in the constraints, the restrictions of the healthcare system that they are in. Another part of comprehensive care is about providing self-management support, particularly in the context of people with chronic conditions. This is an important aspect to provide this support so that they can have the confidence to manage their own conditions. And what we see in Paris results is that fewer people with multiple chronic conditions are confident that they can manage their health. This doesn't come as a surprise because it's always more complex and requires more additional skills and knowledge and experience to manage multiple chronic conditions in most of the cases. So this is also supported by the data that we have in all countries. But what we also see in the results is that when we provide self-management support in primary care, then people can build confidence to manage their own health. Here you see percentage of patients who are confident or very confident to manage their own health. And the rounds show people with confidence with self-management support, confidence of people with self-management support. And then the average confidence is shown in the middle. And at the bottom, you see people without self-management support. And again, the difference across countries are huge. Here you look at France, Netherlands, Saudi Arabia, where confidence is very high, but also the difference, the gap is very small across those with and without self-management support. But in some countries, Australia, Wales, even Canada, Luxembourg, the gap is getting larger when it comes to self-management support. And it also depends on the type of self-management support, right? Here, I'm not really detailing this, but this is also something that we looked in the flagship report. So you can have self-management support with verbal instructions, with written instructions, by having self-management programs, self-management classes, have a separate healthcare professional in primary care setting who can develop this. So there are these differences, which can also make the variations that we are seeing in the data. And another aspect about being confident to manage is about whether patients are involved in healthcare decisions related to their health by their healthcare professional, by their primary care professional. And we see that almost in all countries, when people are involved in decisions, which are the rounds, they are more likely to have confidence compared to those without involvement in decisions. And again, the variation across countries are very large. So moving to the next part, which is about the coordination of care in primary care, which is also an important part of the everyday task of primary care professionals and family doctors, the coordinating role. And one of the aspects that we looked at was about systematic medication review. As we saw, those people have multiple medications most of the time. So it's very important for them to have the opportunity to talk about their symptoms, have any report any adverse events, but also see any interactions, possible interactions, also have deep prescribing practices where needed. So here we see two groups of patients. Those with round are people who had a medication review over the past year. And these ones at the bottom are those who did not have any medication review. And the graph shows experience coordination score. So higher the score, better the experience coordination is. And in all countries, when there is a systematic medication review, people were also more likely to experience good coordination of care. But we also see that this is not a standard practice in all countries. So in some countries, let's look at it, Greece here, we see that There's a difference between people with one chronic condition or three or more chronic conditions, where people with more chronic conditions are more likely to have a systematic medication review. Whereas in some countries like Netherlands, it doesn't really matter how many conditions you have. Also, the number of people who have a medication review on average. So here, for instance, Czechia, Canada, almost 90% of people having this. Whereas in Iceland and Slovenia, we see less than 50% of people get a medication review as part of usual practice. So this calls for further practice identification about what are the results of this systematic medication review, lack of systematic medication review, and how we can address it. And of course, this might be linked to adverse events, but here in this context, adverse events goes a bit further than this. Also about the waiting times when they needed information, when they needed to access to a healthcare setting, or getting information about their health when there was a need. And we see that here you see the number of patients, percentage of patients who trust the healthcare system, who did not have any adverse events in a previous year. And here, with the marks, red marks, you see those who had an adverse event in primary care, and they are less likely to trust in the healthcare system in general. So this is also related to personal experience that people might have going beyond overall trust in the government and so on. So the last dimension is about person-centered care, and then we will wrap up. We know that when people report more person-centered care, they also have better physical health. Here you see the average physical health T-score. This is measured by a scale called PROMIS. But what we need to know is higher scores denote better health, better physical health. And the rounds are people who report good person-centered care, better person-centered care, let's say. And the other white marks are about people who do not have good person-centered care or lower person-centered care. And in all countries, when they have more person-centered care, they are more likely to have better physical health. And the same thing goes for mental health as well. So for those people who had more person-centered care, they also likely to have better mental health as well. And we have also found the same results for well-being of people as well. So this shows the importance of person-centered care in primary care settings from the perspective of patients as well. So to wrap up, what we know about strong primary care is also shown by patient-reported outcomes and experiences. So strong primary care improves their health outcomes and care experiences, yet many countries still lag behind. Here you have three examples to wrap up. The first one is about exchange of information, electronic exchange of information. In the highest performing country, almost 100 of all patients are managed in practices that can exchange medical records electronically, whereas in the lowest scoring country, it's less than 10%, with an average about 50%. Same goes for percentage of patients managed in practices well prepared to coordinate care. You see that the highest scoring country comes up to 100%, whereas the lowest is less than 5%, with an average of 50% of people are managed in practices well prepared to coordinate care. And the last thing is about patients receiving enough support to manage their own health. In countries where this is highly developed, 80% of people get support to manage their own health. With the lowest scoring countries, it's 40%. So to conclude my presentation, the question was, does healthcare deliver? Yes, it does, but when healthcare is centered on people's needs. And what we see is many healthcare systems still remain fragmented, not necessarily addressing all the issues with the mental health, social functioning, and other problems of people with chronic condition, and not well adapted as well. And what we also see is that putting people at the center of healthcare, as this is the buzzword now, people-centered healthcare, making healthcare systems around people's needs and so on. This is just not an aspiration, but it's also a measurable reality that can guide policy decisions. So to give you an idea about what's next for Paris, we'll be continuing working with patients, academics, primary care professionals, and policymakers to continue setting this new international standard. And OECD health ministers asked the OECD to continue and expand Paris. And I'm happy to announce that more people, more countries have already expressed interest in joining the second cycle of Paris, which has already started. And the last one is that what we try to do is we really try to make patients' voice heard. And this will be the only way to make healthcare systems more people-centered. I stop here and I'm happy to hear any questions or comments you might have. You have our coordinates here. Please feel free to get in touch after the presentation as well.
Thank you very much, Candan. It's been a great overview of Paris, the rationale and the findings of the report, and also in a very timely manner, not just in terms of the release of the report, but also literally in terms of the timekeeping. It's been excellent. We don't have too many questions from the audience. Some of them have requested the report, and I've added a link to it in the chat. Some people are expressing an interest in perhaps at an individual level to contribute to Paris, and that's the and I will let you answer to that, while also others have expressed an interest of in the country contributing to Paris. So perhaps you may be able to give some suggestions on how to achieve that.
Thank you. And indeed, it's a question that we are getting very often. How to participate in the second cycle of Paris as a country or as an individual family doctor. And here I should acknowledge a limitation that we have. Because we are an international intergovernmental organization, the only way to get in Paris, in the second cycle of Paris, goes through governments. So the countries, the governments, ministries of health should show interest in joining the second cycle of Paris. And this is how the country will be involved. And then once a country is in, then they will do a sampling approach in their own country to sample primary care practices, to reach out to primary care practices, family doctors, and then to patients. And the only way to get in touch is that they will be getting in touch. So if you really want to participate in the survey, this should come from the country governments and then the sampling approach. But as an individual family doctor, one thing that I think our colleagues could do will be reaching out to your national organizations, showing interest, sharing experience and knowledge about this work, and to connect with the ministries of health or the health authorities who might be interested in joining this. We saw this in the first cycle where primary care professional organizations, family doctor associations, and also WONCA networks initiated a contact with the Ministry of Health, which led to their participation in the first cycle. So I would say that this is the first step. So get in touch with your colleagues in your professional organization and try to create a link with the Ministry of Health to see if there is any interest in joining this. And in that sense, if there is anything that we can do to provide more information about the work and the steps, the requirements, then we'll be happy to get in a call and discuss this more about on an individual case basis.
I hope that, I mean, that's most helpful, and I hope that the audience will find it satisfactory. I would like to, I mean, I was picking up on picking some of the questions on the chat, which were very specific of this topic. I would like to invite now I mean, questions from the participants to Candan in relation to either the findings that she has presented or about the development or implementation of the survey. By the way, let me also use it as an opportunity to announce that the two coming webinars, there will be one by the country national project managers in Slovenia and Czechia about the results in these countries, which two countries that fared particularly well in the report, as you will see when you read it. And there will be a third one in which I myself would give you some details on the background and instrumentation. But I mean, we have now an opportunity to hear from Candan in relation to some of these aspects. So please do not hesitate. If you have any question, just raise your hand, please. Andrew, please.
I want to thank you very much indeed. I am glad that I had the opportunity to participate in this Paris webinar.
Andrew,
I saw it, by the way.
because people may not have read the chat. If you can introduce yourself.
All right, all right. So I'm Dr. Andrew Iyaji, family physician in Nigeria, working in Nigeria, and I have been following up before the reports even came out. It was very interesting, very exciting to see that we can have patients' perspectives from that's very wide-ranging survey. So it was exciting to see when the report came out, and I followed it. I happened to come across this on LinkedIn, and LinkedIn, and I registered either LinkedIn or my email, WONCA emails. So the question I have is, one of them have been answered, but one of the other question I have is, in the course of the presentation, I saw that in the graphs, most of the graphs had OECD PaRIS. And I wanted to be sure, was that like the average finding as different from findings in different countries, or what does it represent?
Thank you,
very
Andrew.
much.
Yeah, thanks a lot. This is an important question that I should have addressed in the very beginning, maybe for clarity indeed. So this is basically across all participating countries. We have some member states which are called as OECD countries, and there are some non-OECD countries in this context. For instance, Romania is one of them, and also Saudi Arabia, who showed interest, but not necessarily OECD member states. So when we say OECD PaRIS average, this is the simple average for a given score or percentage of OECD countries participating in this survey. So excluding Romania and Saudi Arabia in this particular context. But it's the simple average of the score for each indicator that I've been showing from the PaRIS results. I hope this answers the question.
It does for me. I hope also for Andrew. Thank you. Thanks so much. Anybody else in the from the participants may have a question? Okay, so while you think about some of the questions, I the title of the report is whether healthcare delivers, and I think it's an interesting choice because I think it makes most sense read as a thanks, Andrew, for the thumbs up. I think that makes most sense with Paris as perhaps as in the broader sense. No, I mean there have been initiatives to try and to understand what happens in terms of seeing care through the patient's eyes for chronic conditions, but also for breast cancer, for orthopedics, mental health, for a number of different initiatives. But there seems presented like that. There would seem to be a huge inference from what healthcare, primary care, and ambulatory care does for patients, as seen by patients, and the system as a whole. Do you also perhaps recognize a bit of a tension, or is that purely a description of the aspiration of Paris as a source of information in the broadest sense, being able to answer this question?
Long, short answer, let's say, it's yes, this is a reflection of the aspiration because the main target audience of the OECD work and OECD reports is policymakers. And here we are trying to get attention of policymakers to first, primary care, second, how we assess the performance of healthcare systems in delivering primary care. So what we already have at the OECD when it comes to international data collections for the performance of primary care measurement is that we have avoidable hospital admissions, we have prescribing in primary care settings, we have number of general practitioners, nurses. So these are mainly structural and input indicators that we have. But what we try to highlight, stress here to policymakers is that there is another source of information which comes directly from patients themselves. And there have been several pilot initiatives, you know it much better than I do, Chima, about collecting information on patient-reported outcomes and experience measures. But at a scale that is run at national level first and then international level for performance benchmarking, this is quite a huge thing. And what we are trying to address here with this title, Does Healthcare Deliver, is this is what I was mentioning at the very beginning. The whole idea of why we have a healthcare system is that we have patients to deliver care to patients, and we are not necessarily asking them whether we really deliver healthcare as they were expecting, in line with their values and preferences as well. So that's the whole idea of the title, why we chose a striking title like this. And we also want to acknowledge that it's important that I was trying to mention in my presentation as well, that there are things that we can deliver, that we can do in primary care settings, but primary care also functions within the whole healthcare system and most of the time within the limitations of the healthcare system. So we are also trying to acknowledge it, not necessarily putting all the pressure on primary care, saying that primary care is not strong in this country, but we are trying to say is that healthcare performance is not strong enough to deliver good primary care. So that was two levels of attention taking with the title regarding policymakers.
Thank you. And perhaps following that line of thought, I mean, I'm keeping an eye on hands up, and I don't have any particularly appetite. We fortunately have plenty of opportunities with Candan for discussing these issues. So I don't necessarily want to be in the limelight. So any other questions would be very welcome. But while you keep thinking of them, I don't see anybody raising their hand. Okay, so are there any describing this aspiration of I mean of capturing and presenting the information, not just in relation to chronic conditions in primary care, but more broadly, also even considering that in itself, primary care and care for chronic conditions is a significant piece of the system. Are there other similar initiatives that will be related initiatives or within the OECD that will be disseminating related information, perhaps in relation to specific conditions or procedures?
So within the work of the OECD, PaRIS is one flagship work that we are doing when it comes to patient-reported outcomes and experience measures, but we also have other work streams related to patient-reported outcome measures in hospital care settings. So, for instance, hip and knee surgery is an area that is that's existing for a while now, so much older than primary care settings data collection, let's say. And OECD has been collecting data on this since 2018. And we had several rounds of data collections from countries about outcomes of people who go into hip and knee replacement surgery. So we collect data before and after. Same thing for breast cancer work as well. But the outcome is less positive there because it's very difficult to to make a measurement of it at the international level and do benchmarking across countries, so the data are not comparable most of the time. When it comes to experience measures, I think this is not new. In most cases, there have been already several other initiatives like Commonwealth Fund Survey, who have been collecting data about patient-reported experience measures in primary care settings as well. So there are other things. What we are now trying to do is put this in a bigger context in the healthcare system. So PaRIS flagship report is now live there, but also what we are trying to do is addressing some big issues that countries are facing when it comes to, for instance, cardiovascular diseases. This is a big challenge in most countries, we know that. And part of the story, the part of the work that we are doing in cardiovascular also includes data, specific data coming from PaRIS, only for people with cardiovascular conditions. So there are other pieces of work that also take PaRIS data, that use PaRIS data to prepare a complete picture of healthcare system performance in the work that we are doing at the OECD.
Thank you. Thanks very much. There is another question. I mean, this in relation to availability of the questionnaire for local use, and that of course raises also important issues of first adaptation, which is not just because it's available in the same language doesn't mean it's readily available, and also whether that may be the best questionnaire, considering that you may be also considering revising it. But I'll let you answer those questions.
Yeah, about the questionnaires, first of all, they are available already on the PaRIS website. So you can just check them and download both patient and primary care practice questionnaires. This is free of charge. You can just download it from the website. But I definitely agree with you, Chema, that this might not be the best questionnaire that you use at the local level, because PaRIS was designed to make an international comparable data set on patient-reported outcomes and experience measures, build on a conceptual framework with domains that are relevant to this context. And your presentation, Chema, in the next two webinars will be related to this point about the instruments, and I think you'll be answering these questions, but this was particularly related to the international context in chronic care management that we can standardize across countries. But when it comes to individual practice, local practice, then there might be better questionnaires that you can benefit from, on top of everything that Chema was referring to about validity and also cross-cultural adaptability of the questionnaires and so on. But if you would like to have a look at the questions, they are available, and I see Chema who has already shared them.
They include both the patient questionnaire and the provider questionnaire, both of them. Thank you. We have time for more questions. I'm just checking. Okay, we don't have more questions. Is there anything else that that you would also like to share with the audience that you have not had opportunity to doing so? Because of course, when one focuses on the presentation, sometimes there are a number of things that they need to select. Anything else that you would like to add?
Yeah, I think one aspect that I would like to expand a little bit about the contribution of WONCA to this survey, because it has been extensive since, as I was mentioning in the beginning of my presentation, but some people might have missed it. Even my involvement in this project has been thanks to involvement of WONCA, so that I heard about it and get in touch with the colleagues at the OECD. So WONCA was there in 2019 when this was just an idea about measuring patient-reported outcomes and experience measures. Chema, I think you were also in the task force in 2019, right?
Yeah.
18, sorry, not 19, 18. So WONCA has been in the initial task force to share experiences from family doctors' perspective. And since then have been involved in design of the questionnaires, implementation plans, getting in touch with national family doctor and primary care associations, recruiting data. And when we had the data, we had a phase where we had consultations with family doctors, representatives of family doctors and other primary care professionals, where we got advice about which results were really important, how we could interpret them, whether there were things that we needed to be careful while interpreting, what really mattered for their practice. So this was a huge help for the success of Paris. We also had a similar thing with patients and academic experts as well. But in this context, I particularly want to highlight WONCA's contribution. I see Raquel is also in the call. She has been also supporting these discussions a lot by providing feedback on the documents and so on. And we count on WONCA's experience for the second cycle as well. There will be a second cycle where we will revise the questionnaires to make them more fit for the context and measure again really what really matters when it comes to management of chronic conditions in primary care settings. So we'll be continuing relying on the expertise of WONCA, and this is something that we highly appreciate. So this gives me an opportunity to expand this appreciation a bit further. Thanks, Gemma.
Thank you. No, thank you. And if I can expand on that, that's absolutely not just the case. I think there's also a lot of appetite within WONCA to continue supporting the initiative. There is also not just this webinar series, for instance. We also are having we hope to be presenting a workshop together with Candan, together with Viviana Martinez Bianchi, President-elect of WONCA, and others in Lisbon in relation to Paris, and there is strong appetite for WONCA to have a role. Some of the country NPMs are WONCA have WONCA roles. So I think I can see it's been a fertile ground and an opportunity for further collaboration. I'm not sure whether the OECD and WONCA really have had many opportunities in the past, but this one is certainly one that is resulting particularly fruitful for both sides.
Yeah, indeed, same perspective at OECD as well. And I'm not sure, indeed, if we had many opportunities to work with WONCA when it comes to OECD's work. But this one has been a huge success from my perspective, not because that I'm leading that stakeholder involvement in the work, but also because that colleagues have been really interested in the work that we are doing, which also shows that this is relevant for the practice as well. So this is a motivation for us to continue doing this across all these years.
Raquel, may I be cheeky and invite you to reflect on your contributions? Or is it not at the right time of the day? No, perhaps I've been too cheeky. So
No, it's okay. Can you hear me? Sorry,
yes, very well.
I cannot
Yes.
have the video because I'm in the hospital, but I would like to share with our colleagues. I think it's an amazing opportunity. And every time you have the chance to contribute with WONCA, with the OECD or other institutions that are launching this kind of questionnaire, I think it's very important that we engage and provide feedback, because it's how we enrich and improve any data that is being collected. And we all are able to provide some feedback. And I think it's very important to acknowledge that the regional representation or the contributions that we all can bring, and we all have different expertise. So I felt really lucky to be able to contribute and to be part of this fantastic project. And I believe there are other colleagues who can also do the same and contribute as well. So thank you so much, Candan, and your team for this opportunity, and also Chema for leading the work that you're doing. It's really a privilege to contribute. Thank you.
No, thank you. Well, if there are no more questions, then I would please ask the participants to join me in thanking very much Candan for your presentation today, your availability for answering questions, and your energy and passion for it. It's been great to have you, and thank you very much for doing this.
Thank you so much for coordinating it, Chema, and organizing it with colleagues. And thanks for joining us to listen in. I look forward to hearing more.
And and it's really been a shame that we could not have Michael with us. I know that he was disappointed that he could not do it. So
No, yeah.
we hope that everything went well for him. I don't think we necessarily. I mean, it was perfect as it was, but we could. It would have been good to have him too, possibly at a future occasion. Just to let you know, I said that on the 23rd we will have our colleagues from Slovenia and from Czechia presenting on Paris, the same from the perspective of a specific country. And early next month, on the 6th, we also will be reviewing the framework and the instrumentation. By the way, the framework that was developed by the OECD and the consortium was recently shortlisted as one of the 10 top papers for 2024 in the journal where it was published in BMJ Quality and Safety. So yeah, it's both good collaboration and productive and high impact work. So thanks again, Candan, for this, and hope to see you all in our upcoming webinars.
See you very soon. Bye.
Bye.